Hi, how are we?
I'm well. How are you? I'm glad to see you were able to get on okay.
I touched a button and it worked. Yay.
Yay, buttons.
One quick thing before everything starts happening. I did not get a final agenda, so I wasn't able to print it out. And I don't know why, or if I did something wrong and deleted it or something like that, but I don't remember seeing it.
Oh, let me. I thought I had sent that out, but it's possible in the craziness, I may have missed it, but let me send that out right now. Give me one moment.
Okay. I did get your email with your work phone number and with the revised minutes.
Oh, perfect.
Hi, Rashawn.
Good evening, Chair Bruder. How are you?
Nervous.
Well, likewise, a little bit. So, you see, I'm in good company with that.
This is weird. I was telling the wife this morning that it's strange because they're going to be looking at me like I'm the adult in the room. That's just mind-boggling.
You're gonna do fine, Chair Bruder.
I'm sure. I'm trying to channel the Sharon. No, I don't. Oh, I just did something wrong. Uh-oh.
We can still see you fine and hear you fine.
I can see you, but you got really small in the corner of my laptop. Oh, okay, here we come. Oh, and there's Commissioner Stern. Hi.
Damon, did they give you the stick, the control stick to fly the airplane there?
I'm not allowed to have sticks. My wife says it's not a good idea. I have a vague idea of how this is supposed to go. I'm supposed to read from a script that I can't find.
Probably because I didn't send it to you.
Yeah. And Nicole, Ms. Meza is working on sending the agenda because I didn't get a copy of that after our meeting either, at least not that I know of.
We'll
That
pull
doesn't
up the
need-
agenda for you, but I think where we were talking about the script was if we had to actually do a vote on something. And that's the part that I didn't think we had anything we were voting on this time, but I just haven't had a chance to put that together for you.
Yeah, and that's quite all right because you're here and Ms. Meza is here and there's enough people here to help us through all this. So which
Yep.
is great.
Great. Yeah. And again, we are a new commission, and it's okay if we are not perfect.
Yep.
That was my
Yeah,
favorite part of last month's presentation.
Yeah. We're not changing the world tonight. Yeah. So
And Damon, just to let you know, as I look on the screen, there's one person on side of you, above you, below you, and all sides of you. So it's impossible to fall.
yay! Way to
Yeah.
point that out. I like that. That's
Yeah,
pretty
you're
cool.
good. You're good.
Stay in the middle of the herd. That way you don't get picked off.
Yeah.
So I just emailed the agenda and I'll also put it into the chat as well.
Okay, that would be awesome. And I'm the one that's supposed to be calling roll. Is that correct? I don't have a list of. I am completely unprepared for this. I don't have a list of our commissioners.
We can put that in the chat also. Well, I don't know if we actually have an updated list at the moment because we had a couple changes this last time.
Yeah, things are not what they used to be.
Well, we'll wing it.
Hi, everyone.
Hey,
Do we know if we're
Evening.
going to have a quorum today?
I don't know.
Okay.
We have Eric, Damon.
How many do we need for a quorum?
We need 4,
Close.
I believe.
Actually, I think it's one more than half. And we were talking about this last time that if you have unfilled seats, that typically does affect things, but not for our group. So if we have unfilled seats, our quorum number reduces. So I'm going to look it up real quick and see if I can read it to you.
Okay.
It's an unusual exception, actually. So it's one of those weird things that's non-standard.
So real quick, I come up with King, Sturm, Bruder, Hart, Plum. I thought we had one empty at large, and then we also lost Sharon DeJong. So that would make the total of 7 if
Yes.
we count those 2 slots.
Yes.
Right. And our quorum statement in the bylaws says the quorum for the commission shall be one person more than 1/2 of the appointed members.
So half of the 2.5.
2.5.
Plus
So
one.
you're good.
So we need 3.5.
Yeah. We just need 1/2 of a person here.
There you go.
Okay. Well,
All right. So somebody started recording, it's telling me. Does that mean that we're live?
We can be.
I have started recording the meeting. It is
Okay.
6 o'clock.
Well, I suppose we should call this to order then.
but we can't because we don't have a quorum, right? We need 2.5 plus 1.
Oh, you have 3 right now.
Yeah.
You're good.
I'm sorry. Then I realized I don't know you. I know Damon, but I don't know this face, this new woman's face that I don't know. I'm sorry. On my screen, you're on the top right. You're the person who just said I've started recording.
Oh, I'm the admin.
I don't know
That's
you. I'm sorry.
Hi, Nikki Mesa. You get the. I'm the one.
Oh,
that sent the
Nikki.
email. Yeah. Hi.
Ah, great.
That's me.
Good.
On the question of quorum, Patty, you have 3 commissioners right now, and we only have 5 appointees, so you're okay.
Okay.
Mm-hmm.
All right. I'm with you.
All right. So I suppose we should call this meeting to order. Welcome everyone to the SSP Advisory Committee meeting for September 14th, 2021. My name is Damon Bruder. I'm acting chair of this committee. I feel that we should take roll. So, Commissioner King,
Here.
Commissioner Sturm,
Present.
Commissioner Hart. No Commissioner Hart today. Commissioner Plum. No Commissioner Plum this evening. Chairperson Bruder is here. We have 3 commissioners. That gives us a quorum. So here we are.
Okay, great.
I'm trying to see in the chats where the agenda is, and I'm not.
I am uploading that as we speak.
Ah, yay! Hopefully, I'm looking in the right spot too.
Going
Right.
in right now.
Now we have a +1.
Here we go.
Okay.
All right.
That's
Are
not-
you able to see that, Chair Bruder?
I am not. I don't think I'm pushing the right button.
I can share my screen so everyone can see it if that's helpful.
That may help at the moment.
How about that? Can everyone see it?
Oh,
I can
the
see
agenda
it.
just came up in chats. It just came up.
Great.
Awesome. Now I just have to get it to show up. Okay, I'm going to use the shared screen one so we can get this going on the road. Okay, roll call and introductions. We did that. Okay, item number 2 on the agenda is review and approval of the minutes from our last meeting.
I move
has
that
everybody-
I move that we approve the minutes from the last meeting.
Okay, we have a motion from
We need a
Commissioner
second.
King.
I second.
Okay, we have 2 seconds, or we have a second. So all in favor of approving the minutes from last month's meeting, say aye.
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 Aye. That's
I'm here now.
unanimous. Hi, Commissioner Plum. Welcome.
Thank you. Sorry I missed the roll call. Technical issues. I'm here though.
Yeah.
Great.
So item 3 on the agenda is program updates from Mr. Rashawn Williams, the program coordinator, and Jen Herrera, the HSA assistant director. Who wants to go first?
Where's Rashawn? We lost Rashawn.
Yes, I will go ahead with the program updates, and I will try to make this as speedy as possible. And forgive me if I have some technical difficulties here, but I think I'll be able to navigate through them. I'm going to share my screen. Right. And hopefully we're looking at the same thing here.
Yes.
Okay. Again, forgive me if I stumble through here a little bit. County of Santa Cruz Syringe Services Program updates. My name is Rashawn Williams, and I am the Santa Cruz County Syringe Services Program coordinator. And there we go. Okay. Current activities. As requested, I will be sharing the August 2021, which is this past month, and doing a comparison with the August 2020 data reports. Also giving an update on HIV and hepatitis C testing preparation, an update on the Watsonville Exchange, and a note on working towards participant surveys. The Santa Cruz County Syringe Services Program posts data reports monthly and they can be found at the webpage. Just go to at Syringe Service Program, santacruzhealth.org. Data reports reflect program usage by participants and persons who conduct secondary exchange. Data reports reflect demographics of persons using our exchanges, including but not limited to area of residence, ethnicity, age group, housing status, and injection drugs used. The data taken for this update is from our posted reports from this past August 2021 and August of 2020. We will look at participant use of Santa Cruz Exchange and Wattsville Exchange, Syringe Service Program syringe dispensation and collection via exchanges and kiosks, naloxone distribution, and education and referrals. Again, this is gleaned from reports and just some elements, but not everything on those reports, which can be accessed through our website. Right here, we have visitation and unique client IDs. It's split between the Emmeline Exchange and the Watsonville Exchange, and then the total usage. It includes a frequency of visits, those who visit multiple times, etc. This is for this August. And this is last August. Again, I'm going to point out up here that this 85% indicates 85% of the total visits were at the Emmeline Clinic. Right here, 15% were at the Watsonville Clinic. And over here, it's the total visits for the 100%. Participant usage of our exchange has declined when looking at both these Augusts. Participant uses for the county exchange has declined at both exchanges by approximately 27% when comparing unique client IDs from August of 2020 and August 2021. Overall visits have declined 33%. Syringe dispensed and collected by the Santa Cruz County Syringe Service Program. The Santa Cruz County Syringe Service Program only distributes syringes through our exchanges. Syringe collection is conducted via exchanges and kiosks. Hours of operation have not changed at our exchanges from last August, either at Santa Cruz or Watsonville. We have deployed 2 additional kiosks since August of 2022 or 2020, sorry, working with the city of Santa Cruz to decide on their locations, which are at the San Lorenzo Park and off of Felker Street. We have August 2021 syringes collected. Again, this is Santa Cruz, Watsonville, and totals. August of 2020, again, Santa Cruz, Watsonville, and totals. Syringe distribution and collection via our exchanges has declined. We are distributing and collecting approximately 40% of the number of syringes this year compared to last when looking at August numbers. When comparing our Watsonville exchange in isolation, the decline is less, and down approximately 25% for syringes distributed and 15% for syringes collected. Syringe disposal via kiosk use is up. We collected approximately 33% more syringes via our kiosks this August compared to last August. Naloxone distribution. We continue to distribute Narcan via our exchanges and act as a resource for Narcan access and training for our community partners. In August of 2021, we distributed 449 Narcan kits and 40 reversals using Narcan were reported by our participants. There are 2 doses of Narcan in each kit. So for our nasal Narcan, we have 2 doses. And also for our intramuscular or injectable Narcan, there are 2 doses in each kit. Our August 2020 numbers, you see less Narcan kits distributed, but also less overdose reversals reported. Overdose reversals are reported by primary participants and do not account for the numbers of reversals performed using Narcan distributed via our exchanges to partner organizations. Education and referrals. We have increased our efforts to engage with participants during each encounter, emphasizing education on overdose prevention, treatment for substance use disorder, and harm reduction. This is a look at our education numbers for August of 2021. The 93% is an indication of drug treatment, education, referrals included. They are mingled. We do not separate them. So for last year, we were reporting education and referrals with a far more narrow scope and only including those encounters where there was, I would call it, rich engagement, where the individual gave an indication that they were going to seek treatment. Also, calls made and direct referrals were included. See, harm reduction, that's a standard. Every time persons enter the exchange, we do have, well, firstly, education offered. We do have literature throughout the exchange. But when we engage people to offer, say, alcohol wipes and give instructions on how to clean off one's skin prior to injecting, using a new sterile syringe with each injection. Those are just a couple examples of engagement that we perform with our participants to do what we can to offer tools for harm reduction. You see pharmacy referrals, they are at 0. It's a rarity that we refer someone to a pharmacy. That is, if someone presents without syringes and we're unable to give them a referral to the clinic because the hours don't jive, which is to say that the clinic is not open during the exchange hours, such as this moment right now, we wouldn't be able to refer them to the clinic. So we might refer them to a pharmacy who will sell syringes. An example of that is the CVS in downtown Santa Cruz. Or we, depending on the day, can refer them to the Harm Reduction Coalition of Santa Cruz County. Again, our first effort is to refer them to one of our clinics if they are open and we're able to do a warm handoff, for example, when our hours sync up with the Emmeline Clinic. HIV and hepatitis C testing. We are working to start referring people, even though we're not doing testing right now, but we can refer them to their primary provider or the Emmeline Clinic. In overdose prevention, that again is a standard that we engage each participant by asking if they want Narcan or naloxone. Those numbers that are not quite at 100 are either error in the field is not clicked, or there are occasions where there is an exchange and the person is in a rush and the staff person says, you know what, during that exchange, I did not bring up Narcan. You know, there was some kind of issue where Narcan was not brought up. Same with drug treatment and harm reduction. These are our 2020 numbers. You see that the drug treatment referrals are way down in 2020 when we were defining education and referrals for drug treatment in a much more narrow scope. You see our improvement in harm reduction and also overdose prevention education referrals as well. We are considering a format changes to our data entry to better reflect the difference between education offered and referrals. That is something that we're discussing as a team and also with our IT department to potentially change our database entry fields to capture referrals in a separate section. So if and when that happens, which I believe it will, we'll see if we actually put that on the data reports. It might be something that we do. But again, that's a discussion that we'll have to have as a team and make our decision based on that. But we do want to improve our data collection as it relates to referrals and then work on tracking successful referrals. It's always going to be a little bit difficult because we are an anonymous program. And once you track a referral between agencies or providers, you're losing that anonymity and you are going into the participant giving authorization to share information. So it gets a little complicated. But as we are tracking things now, such as reversals out of overdose, that's participant feedback. HIV and hepatitis C testing. We are moving our target date of October as a start for HIV and hepatitis C testing and linkage to care to November. We're still just working through some kinks, and apologies for that. I want to start that as soon as possible, but we do have just some things to work out, especially as it has to do with referral to care. If we're not able to link someone to care who tests positive, data shows that the successful linkage falls right off, and it's really a paltry number if we're not able to link the person to care immediately. And we will change our Wednesday afternoon Watsonville Exchange hours at the start of October. That is something that we're going to implement at the start of October. They're currently from 3:30 to 4:30 p.m. and we're changing them to 2:30 to 3:30. And that is in part response to improving that linkage to care. When we begin testing for HIV and hepatitis C in Watsonville, the lab is not going to be open past that 3:30 time. And we do want to make sure that we are able to link people to do confirmatory testing if they do test reactive or positive when we do the test through the exchange. Watsonville Exchange construction. We continue to operate our Watsonville Exchange out of Suite A on the 1430 Freedom Boulevard campus. Construction should be complete and we should be moving into the new exchange in the coming month. We're already ordering furniture for it and it's almost done. I'm actually going to be down there tomorrow to look at the facility and meet with the staff regarding testing. And participant surveys. We will begin conducting monthly participant surveys in October. That's something that we wanted to do for a bit, but just haven't got on the ball with implementing it. We'll start with asking our participants the times they would prefer our Watsonville Exchange exchanges 2 additional authorized hours to be added. This is something that we did when we expanded our hours in the M-Line exchange. Is we got participant feedback as widespread as possible, as far as not just surveying people here in Santa Cruz, but also some in Watsonville, and we'll do the same. But getting participant response to see which hours they would like and what days they would like those expanded hours to be placed on is going to be key to, really getting buy-in and getting actual participation from our target population when we do expand those hours. And again, getting that data ahead of time so we can then plan and make the decision with their input in mind. And of course, staffing is a key to being able to actually move forward with those hours and the days of operation at the Watsonville Clinic. Well, that was short and sweet. Thank you very much. And again, regarding that data used for the earlier part of the presentation, we have data reports which are accessible on our website. And that goes back all the way to, I believe it is 2016. So you can look at past months if you want to do a deeper dive. And feel free to do so. I actually encourage it, and that way you can, have a richer background and more informed questions and suggestions.
Thank you, Mr. Williams. We appreciate that. A lot of good info in there. I'll have a couple of comments in a few moments. I see Commissioner King has her hand up.
Okay, so please remind me, when you're talking about unique clients, it's just that you might have had whatever the number was, 142 unique clients means different people. But that doesn't necessarily tell us whether or not these unique clients for this period of time also came last month. We don't know if they're new to the program. Is that correct?
That is correct. We don't have a category for new clients in our data report. It's just month over month, how many, as you indicated, how many unique clients codes individuals came. So if someone comes on, August 31st, and then comes the following day, they're going to read as, in the different month reports, even though it's the same person that came each week or within the same week, they'll read separately. But the unique client code means that if someone comes 10 times within one calendar month, it's only going to read as one.
Anecdotally, do you have a sense about how many new people we might see in a month?
I'd be a little hesitant to throw out the number, but we get new people each month. We do.
I think I'm wondering, really, how do people find out about our clinic?
Well, through outreach, through word of mouth, and I would say those are the two main ways. Through outreach work conducted by our staff members and the MAC counselors in Watsonville conduct outreach as well. But that's really targeting some of their other programs that they work under. But I always try to give persons plenty of resources such as wound care kits, Narcan, etc., that does have our hours and other resources listed in those kits. When we had persons working in the exchange, and we have them still, but when there is regular outreach conducted by persons working in the exchange, I feel that it does improve participation. We had quite a bit of that last summer. Some of our COVID response workers were also extra help workers were doing shifts in the exchange, which has tapered off a little bit. But yeah, again, word of mouth and outreach.
Okay, thank you.
Are there any other commissioners that would have questions or comments? Mr. Stern? You're muted, Mr. Stern. Oh, there we go.
Yes, I finally found the button. I'm just going to rifle through some questions for Sean. Thank you for your presentation and getting all that together. I know it takes time to do that. Do you know why we saw the numbers decline? Why that was my big question when I was listening to your presentation. The numbers are down from last year. I guess that's a good thing if less people are using, but do you have any sense of that? I'm not going to pin you to your answer.
Well, I'm always hesitant to say, okay, well, this is the cause, and there are multiple reasons, I'm sure. One thing that I would point out is that we do not have as much targeted outreach being conducted, advertising our hours at this time. We had one particular employee who did a fantastic job for us, and she split her time doing outreach and working in the exchange, and was actually, recruiting, in essence, participants that she encountered to come into the exchange. And that's a great help. We are starting the interview process, something that I didn't include on our updates, for an extra health program specialist that is being funded through our Cheery grant. And they're going to be targeting the South County primarily. There will be some crossover work, but again, it is in an effort to expand our participation in the South County. But that person is going to be tasked with doing outreach as well, and specifically for the exchange. But again, to point to specific reasons, it's hard to say. It is.
Okay.
I know that we do have another exchange operating in town. They're doing a great job in outreaching as well and reaching our participant population. So that could be a part. And then also the staff for that program, because of their own funding, they're not visiting the exchange as much. So, or it's almost dropped off to nil because they have alternate funding. And so that is a drop in participation because we don't have those staff persons conducting exchange for themselves. There are some primary exchangers and secondary exchange. But, as far as matching this number and that, it's hard to attribute it to one specific thing.
Jen, did you have something?
I did. Yes, I do also want to emphasize Rashawn's point about outreach. So we do have our Ssp locations are at fixed sites at the Emmeline location and over at the Freedom campus in Watsonville. And that when we did do some focus groups in 2019, that was some of the feedback that we received is just we're not the most accessible of sites. So actually a lot of our participants were more housed than unhoused. So it's individuals who have some means and some stability in their lives to be able to access our site, because we're kind of a little bit further out from where people would typically be. So that has something that that is something we're aware of, and we've tried to increased our hours with participant feedback to identify which hours would be most appropriate. We're doing that over in Watsonville. We had done that over at Emmeline. During the shelter-in-place pandemic last year, that's when our SSP staff actually did outreach directly over in some of the encampments, and were able to get some participants to come in. But really, that's not a component that is routinely built into the SSP program. We really rely on other partners to do outreach on our behalf, such as Homeless Persons Health Project or the Harm Reduction Coalition, since they are more field-based, or even some of the clinic and MAT counselors. So when they do outreach, they advertise about our services. But I do think that the surveys that we're going to be conducting for the Watsonville site is an opportunity for us to poll our participants again to see what else we could do to become more accessible. But I did want to share that when we did do focus groups in 2019, it was our locations were identified as not being the most easy to access.
I'm going to move on. I just had a couple more questions. Rashawn, back to you. You mentioned that you're reworking the data collection, the fields for data collection. And I'm just thinking forward, if we ever ask for grants or apply for grants, that there may be data that the grants might want. So we don't want to cut ourselves off. I'm going to stay out of that conversation. I'll leave you as an expert to decide what fields to collect. But I do know when we apply for grants, having done that myself for other things, all of a sudden we go, wow, we should have had a survey or collected data on something that we didn't have and we wish we had.
Yeah,
I don't know.
Thank you, Commissioner Sturm. And that is that is something that we are considering. However, we want to avoid collecting data just to collect data. It should have a purpose, and we already have. It is an anonymous program, and I'll use our information for injectable drugs use as an example. We get participants who don't feel comfortable, even though it's an anonymous program, divulging which injectable drugs they're currently using. Some people, they're hesitant to give where they're currently residing. So there's we want to collect information. I do emphasize that. It's for demographics. It's not trying to get something specific on you. We have our client code, so it's anonymous. But we want to make sure that when we do collect data, that we're able to give a reason for it and an end purpose. With the want to change up the fields a little bit, that is actually in part to get richer contextual information for grants. We do get requests for numbers of successful referrals, and it's just a difficult question to answer. It is, and we do need to improve and do better in that, but it's a difficult thing to work through, and we have to do better at it. I'll have to do better at it, which is part of why I'm saying we are working at changing some of the fields. We will be, and really the beginning of testing for HIV and hepatitis C is a good prompt for that. We do want to collect better data on that. And so we are going to need to make those changes and start using some of the fields more strategically.
And my last question, thank you. My last question is, when the new exchange is open, can you send us pictures?
Gladly, you know, when we do, I will take photos and put them on the presentation, all shiny and new. Yes,
All right.
gladly.
All right.
And
We'll hold you to
it is coming along. It is coming along. I'm telling myself that I keep saying that, but it's moving along a little slower than I'd like, but you know, work is being done. It's almost there.
Bravo. Thank you.
Thank you, Commissioner Sturm. Commissioner Plum, you have things?
Yeah, I have a couple questions. Am I muted? No, I'm not muted. Good. You were talking about outreach. Is there any outreach that's done at the medical level, like patients should be admitted for needle infections, or people presenting to clinics, you know, with outpatient needle infections, and maybe track those and see if we have any impact on those? That takes two questions. One, are we tracking them? Two, are we doing any outreach directly with those people who are coming in with clearly they're having dirty needle complications?
I can start by answering that question. So no, we're not collecting that information, but that sounds really interesting to see if there's a possibility to track that. And then to your other question of outreach to, I guess, either healthcare systems or, you know, how are we working with those partners? And Rashawn maybe would be able to speak on this more, but there is a Safe RX coalition. So that's facilitated by the Health Improvement Partnership of Santa Cruz County. And it includes healthcare partners, including our hospital partners. The goal of this coalition has really been around safer prescribing practices, but it's really evolved to address substance use in general. And it's been a great venue for healthcare partners to engage and talk about, you know, the presentation of SUDS in an emergency room. You know, how do you link someone from who presents over in your hospital? So I know that they've had discussions around there, but I'm not sure, Rashawn, maybe if you're aware of any strategies that have come from those discussions.
No, I would say not. I have you know, distributed our hours and flyers, but as far as seeing where they are posted, as far as at different clinics, etc., I can't speak to that to see how successful that's been.
So, related to the question, are we getting any feedback from those healthcare partners that are doing the outreach in terms of how much interface they're having, or what their experiences are, and maybe working together in terms of improving the quality of the outreach? Harm Reduction Coalition and the Housing Coalition. Are we communicating with them?
Yes, we communicate regularly with the Homeless Persons Health Project. They're a key partner, and we team up and communicate regularly with them, including providing kits for distribution during outreach, 100%. And the Harm Reduction Coalition as well. I communicate regularly with them. We have monthly meetings, and then also find ourselves in many of the same forums, and try to not just during our scheduled meetings, but just periodically as things come up, I will reach out to them. They will reach out to me regarding, you know, supply chain issues, etc.
Are they collecting any data points that would be useful for presentation to our commission?
You know, I would not speak to the data that they collect. I simply just I don't know their operations internally. So as far as what data they are collecting regularly, I'm not sure. I know that they have the data that they need to collect, as far as syringe distribution and collection, etc. But yeah, I will zip it and not comment too much on their data collection.
Have we made any progress in terms of communicating with the numbers from our sister SSP that's also apparently taking some of our business, but we maybe get a better sense for what's really happening in that entire county? It seems like we'd want their data and they'd want ours.
Well, they get our data. We put it out, and we have our reports. As far as communications with them to see how much they've expanded, or their distribution is taken off. Well, I do have some, just in conversationally, some anecdotal, things that I get from them, like, like our numbers are down a little bit. Do you have increased numbers, increased calls, and just conversationally. And they do have a report that they send in to the state. But again, with their data points, I don't have, any of their data in front of me. So I'm just hesitant to speak too much on it. Other than, I know when I look at my numbers, I do, it springs up on how competition, but not really.
Right.
We're targeting the same population.
Right.
We are both aiming to improve the health of IV drug users.
Right.
Our methods are a little different, just because of our program mandates, but our goals are the same.
Do you think they'd be willing to share their monthly reports?
Again, I'm not even sure if they have monthly reports. I don't believe I do not know if they do have them, and maybe in time. I don't think that they're willing to share them right now, though, but maybe in time.
Is our relationship frosty with them?
No.
Right.
No. Our between programs, we have, I have good relations with them.
Good. Yeah, I think you would. Great.
I think I will add, though, because this has been said in public record that they are currently in the middle of a lawsuit right now, and so that is one of the recommendations from our council is to not have too much interaction, but unfortunately, but I will say that from a program standpoint, we're working with them as needed to ensure that we're supporting the public and people who are injecting drugs.
I have one more question. Is it possible to trend the monthly data that you report? What I saw was just individual reports, and I can certainly scroll through them month by month, but a trending line might be useful.
Yeah, I think that I could create a graph. We have the reports that we post in the PDF, but they're in Excel as well. So yeah, I'm pretty sure that we can get a graph. Of course the trend line, the parameters of that. If there's a request for that, but either that or maybe I could just do it over a 2-year period. But yes, it is doable for sure.
Great. Okay. Thank you.
Commissioner King, you had more things?
I do. I think my questions run along the same line as Commissioner Plum. If you are a client in this county, why do you choose to come to our program as opposed to just working with the Harm Reduction Coalition, which, I don't know enough about their system, so I don't know what they're doing, but why does one person choose us over them? And is HIV testing a draw? Like people want to know that about themselves, and so they come to our program with that in mind?
I will say that I know for some, HIV and hepatitis C testing will be a draw. Yes, I can say that with some confidence. I've had participants come in who are anxious for a program to start that, I've had to refer them to other providers. Some are a little hesitant because there is so much stigma around that, even within their provider network, or at least that they perceive within their provider network. So they'd rather do it at least initially anonymously through the program. Although, when it tests, it's sort of lose some anonymity. But anyways, yes, that will be a draw. As far as other motives, one of the surveys that we're going to be conducting is going to be about supplies. So we do try to carry supplies that will, not only help with our participant health, but also be a draw. Some persons do prefer, to come to a fixed location. We're open 5 days a week. The Harm Reduction Coalition does not operate on Tuesdays and Thursdays. That's actually going to be something that we take into consideration when looking at our expanding hours in Watsonville. So there are various reasons, but I don't know. It's hard to say as far as a group.
Does the Harm Reduction Coalition offer the same kinds of other healthcare kinds of supplies like that you're describing, medical supplies, or are they simply distributing syringes? Do you know?
I know that they are offering more supplies than syringes. Yes, I do. As far as what their supply list is, I can't say.
It's actually listed as a requirement to be a state authorized exchange that you provide an array of harm reduction supplies. So cleaner injection materials, as well as other harm reduction things like hygiene and condoms and things like that. So that is actually a state requirement of anyone who's receiving funding for their exchange.
For the population that we have in our county, which I realize is kind of hard to pin down, I'm wondering, just as a citizen, how helpful it is for us to have these two, what looks like competing services. Educate me about why they're not competing services, or are they competing services?
And
the harm reduction.
If I may interject here for just a moment, excuse me, pardon the interruption. The county has been advised by their legal counsel to not talk too much, comment much, have more than necessary interaction with the HRC due to the liability of the lawsuit that's going on. The HRC does have a web page and a Facebook page that you could go and research on, so as Mr. Williams and Ms. Herrera don't keep getting put in the position where they have to say, we can't say much, we don't know, we can't say much, we don't know.
Okay.
It may be better to search like that.
Okay, I get that. Okay, that's it.
Thank you.
Chair Bruder, thank you so much. I would like to provide a brief comment to Commissioner King, if that's okay.
Yes.
So I do want to emphasize that we do not see ourselves as competition with HRC. I mean, that is sort of the scope of social services, is that there's always a lot too much work for one agency for any type of social service. And so we really are working to partner with them, because what they are doing the way that they have their program, which is more field-based and home delivery, that is a very different model than what we provide, which is a fixed location. So our community benefits by having sort of the array of access. But I do want to emphasize that when it comes to any social services, the county, we do not ever see ourselves as competition. In fact, we see ourselves as filling a gap. And if another organization is willing to pick up, we'll partner with them to ensure that we are serving the community as best we can.
Thank you. I do have a couple of comments concerning your presentation, Mr. Williams. I appreciate it. I appreciate all the work that you put into it and to everything else that you do. I'm going to sort of work a little bit backwards. I guess the first thing I would like to say, just commenting on Ms. Herrera's stating that one of the points of the last surveys a couple of years ago was the accessibility of the clinics. I have to agree. I know that when I was homeless and running around, I was more concerned about where I was going to get food and where I was going to get my next fix. And the Emmeline Clinic is nowhere near any source for any food or anything like that. It's a long ways to trek, way off the beaten path, and it takes a long time to do when you're walking and when you're carrying all your stuff. So accessibility, yeah, that's a bummer. It was much easier for me when there was a SSP down on Front Street back before the county took it over. But fill that niche a little bit because they do the home deliveries and they are a more field-based thing. So I'm sure that has something to do with the numbers coming down. As far as the unique clients that come in every month, so I don't have the chart in front of me. Was on the chart, is there a total number of clients or a total number of visits? You're muted, Rashawn.
Oh, sorry. Yes, there is, and bear with me one moment. I should be able to bring that up.
It's not imperative that I see it at this point. I just didn't notice it when I was looking at the other data. So unique clients is, that we had, let's say 20 unique clients, but we had 93 visits. So we don't know how many visits each unique client is making. That's not being tracked, correct?
So you're asking how many visits a unique client is making within a month? Correct. Okay, so no, we don't exactly track that. We are able to glean it, but as far as the monthly report goes, we are able to see multiple visits within a month. So participants who visit multiple times within a month, that is a statistics, that's a percentage that we do have in the report.
Okay. I was just curious if that was available if we were to dig around on the chart. And so
yes.
That's awesome. That's great. So I can dig into that later at some other point. I just wanted to know if it was there for me to find. So that's great that it is. Mm-hmm. The next thing that I just wanted to say, I feel that when you're changing your data points, your data collection things a little bit, and you said that there's going to be more specifics on the medical referrals. Where it says, i.e., wound problems, that kind of thing. I think that is a really great idea to have more specifics for medical. I mean, did you refer somebody for a broken leg, or did you refer them because they have an abscess, or did you refer them because they fell on a knife at their campsite? I think that would help our community be able to push more dollars in proper directions to have that kind of data, that specific data. So I think that's a really good idea. And the last thing that I have is when you're taking the surveys, which are going to be great no matter what the questions are about, I think there should be surveys randomly about different things, with purpose, of course. When you're changing the hours at Watsonville, specifically, you said you were going to be dropping them back an hour in the day from 2:30 to 3:30 instead of 3:30 to 4:30. When you do that, will you offer a week or two or a couple weeks of overlap time so people can adjust their schedules accordingly? Because you're going to get some people that show up at 3:30 thinking that you're open, but you're just closed. And I was just wondering if there would be a little bit of overlap to help them adjust.
To be frank, we were not planning on overlap, because that would be, well, I shouldn't say all the becauses, but that would be an expansion of hours. Within that time, there could be staffing issues. What we are going to do is start to advertise that. I'm actually bringing some flyers down tomorrow to start getting the word out that those hours will be changing. But yeah, we're going to try to get that word out as much as possible. Have some information that goes out during outreach. But it's always a little difficult during, when you make a switch, that day that the switch happens, inevitably there are going to be some issues. So, the hope is that, we're able to avoid it, maybe catch some people by letting them know ahead of time when the switch is going to happen. But
I'd like to add too that it's per board. Our hours are also per board directive of how often we can be open. So that would be something we'd have to check as well, because I think it dictates per weekly hours. And I just can't remember what it says for Watsonville.
Right. Yeah, it stems for me. The question stems from, say, my wife volunteers at the soup kitchen, and it never fails that when we have the change of the clocks, you get 5 or 6 people that show up an hour early or an hour late, 5 minutes after it closes, saying, I forgot about the time. And having like an extra 10 or 15 minutes for a couple of days really helps them adjust, to have just that little bit of flexibility. And I just thought maybe, I didn't know if you might be able to be planning that in there, or, I know the board says, you have to do X, but, just a little fudge flexibility would, might help a couple of people. Just a thought. That was just a question.
It's a really helpful suggestion too. Thank you.
Okay, that's all I have. And I think we're sort of running a little long here already. I think Ms. Herrera has part of a presentation to do for us, which is still part of item number 3 on the agenda.
I was actually just here to support with questions, but I do want to share my screen. Just one moment. Hopefully I can get this to work. Just to let everyone know where to actually find these data reports that Rashawn mentioned on our website. Just one second. So I put the URL or the web page in the chat. So the short URL is santacruzhealth.org/SSP. That's the fastest way to get to the website. And when you get there, this is our program page. We do keep it updated. This is where all of the SSP Advisory Commission information is, all of the agendas and minutes, and even the videos from the past meetings. If you scroll down here, we have the data reports and updates. Select report, and as Rashawn mentioned, we have up through June 2016 reports. When you click on a report, it pops open a new window that looks like this. So the reports are available as a PDF. So this is the same information that Rashawn covered. And in addition to all the demographic information and then the syringe collection and distribution information, we also have a graph So you can see the number of clients per, or the number of visits per day. So this one is from 2017. And just emphasizing sort of the general trend, we have seen a steady decline of participants over in our exchange over the years. So in 2017, we had a total of 226 unique participants. In 2018, we had 185 unique participants. 2019, it dropped to 138. 2020, 135, and then we did have a pretty significant drop in 2022, 99 participants. And as Rashawn mentioned, it's really hard to actually determine the causation, but it is something that we're taking note of and trying to figure out how to be more accessible for participants. And that is all I have. Thank you.
Thank you, Ms. Herrera. Appreciate it. Thank you, Mr. Williams. Appreciate everything that you do also. Okay, so moving on to item number 4, we have presentations in subsection A. It is a National Overdose Awareness Day, and it covers Narcan distribution, overdoses reversed, and Narcan training. Who's got that?
All right, I'm going to share my screen again, and forgive me with the clunkiness of the slide presentation. I don't want to lose myself on the screens when I set up the slide presentation and not be able to work through it, so forgive me. Okay, County of Santa Cruz, naloxone distribution and training. August 31st marked International Overdose Awareness Day. Event organization was spearheaded by the Harm Reduction Coalition of Santa Cruz County and SafeRx Santa Cruz County. On the 31st, there was a virtual event and an in-person event held at the Community Bridges in Watsonville from 4:30 to 6:30 p.m. SSP staff were not able to attend the in-person event. It conflicted with our Emmeline exchange hours. So actually, I didn't check and see if any of our other staff were able to attend. I know that the county did have some people attend, but not from our SSP staff. The county SSP did help with advertise for the event through our exchanges, and we assisted with some translation of event flyers. We had a goal as a group to present in a more bilingual manner, which is part of the reason for holding the event in Watsonville at Community Bridges, where in the past, at least for the last couple of years, not including last year, which it was virtual, which we had a virtual event here this year too, but it has been held in Santa Cruz, from what I understand. The county SSP did provide nasal Narcan for distribution at the in-person event as well. The County of Santa Cruz SSP provides nasal Narcan and injectable or intramuscular Narcan. We offer Narcan with each exchange and use this scripted prompt as an opportunity to discuss overdose prevention in more detail. We collect data on Narcan distribution through our program and participants' reports of overdoses reversed using Narcan. Again, that is participant feedback. It is anonymous, and we do try to dive in a little bit to make sure that we're not double counting reversals. So, for instance, if someone comes in and says, "Oh yeah, I reversed some people just last week," and we try to dig down and say, "Okay, so did you administer the Narcan?" Just to make sure that 3 people who are in the room are not all reporting that they performed a reversal, and then therefore counting 3 reversals when it was actually only 1. Overdose prevention planning. There is more to overdose prevention than having Narcan on hand. The county SSP is a resource for fentanyl test strips as well. And again, when I say we speak to our participants with that scripted prompt to see if they want Narcan, it's an opportunity to engage further in to discussions of overdose prevention. Fentanyl, we make up kits for fentanyl test strips, which include a reservoir for water, a Q-tip, instructions on how to perform the test that are stuck to a plastic bag, and the kit itself, or I should say the test strip itself. And we also include flyers, both in English and Spanish. I've given an example of one of the flyers that we have, the English side of it. We print them 4 to a page, so we're able to have a quarter sheet with Spanish on one side and English on the other. We put 2 flyers in there right now. One is for preparing the test strip for persons who are testing methamphetamine, which takes more of a dilution to get a better result. Otherwise, there are a lot of false positives. And as I say to our participants, better a false positive than a false negative, but you do want as accurate a test as possible. And if there are too many false positives, then people just lose any confidence whatsoever in the test, and it becomes useless. So as I said, we do have the wording of one of those flyers in English. So a warning that, hey, not all tests are 100%. Although the tests do test for most fentanyls and analogs, there are some that are not going to be picked up. Then also some other keys to overdose prevention. Don't use alone. When I'm distributing Narcan, when we distribute it from our exchanges, I say a couple things. Firstly, if someone says, oh, no, they don't want it, I let them know that, well, even if one is not using an opiate, fentanyl is being cut into a lot of different drugs, and there are mistakes made with opiates as well. And if one is using alone, even if they have all the best planning, they have their Narcan on hand, one cannot administer Narcan to themselves when they're in an overdose. So if one does not have someone with them, then even if they're surrounded by Narcan, unfortunately, no one's going to be able to administer it. There are also information that we give out. There is a number that persons can call. It's never use alone. And if someone is going to use alone, they can call that number and at least have someone on the other end of the phone to be able to judge if the person is in an overdose and not responsive, and they'll have gotten that person's information to be able to call emergency response or another individual that the person who's going to use has given them contact information from. We also have take it slow. So in essence, hey, if one is testing out a supply, take it slow at the start, because fentanyl, its potency varies. It's all very strong, but it's not something that is unfortunately a reliable potency, especially in the illicit market. And so it's just advisable that someone take it slow initially to judge their supply, and then have Narcan ready. Also, our county exchange website and contact information is on there. Our Narcan kit are distributed with brochures, which include instructions for use and contact information for substance use disorder or SUDS treatment providers. This is Substance Use Disorder Awareness Month. We try to post some information through our exchanges to sort of get the word out, elevate awareness around this month. But well, to be frank, it's really not something that's at the fore of people's minds. So we don't want to present as too preachy or pushy, but we do try to raise some awareness. We discuss participants' prior experience with and use of Narcan when we're distributing Narcan. We have expired nasal Narcan to offer participants the experience of opening a dose, holding and pressing the injector to simulate actual use. Many of our participants, they're very familiar with the use of it, but sometimes we do get someone who is new to it, and we have to give the full breadth of instruction. We dispel myths, e.g., someone needs to be breathing for the nasal Narcan to work. Again, that is something that having someone practice on an expired dose sort of gets the point across that it really is an easy process, and it injects it into the nasal cavity. But that is also a reason to train people to get all the way up into the nose, as opposed to just barely into the nostril, in order for it to get up into the nasal cavities. As well as some persons are under the impression that a injectable Narcan has to be injected into a vein, which is also not true, just basically a meaty part of the body. I usually advise people to inject into the thigh or the glute, butt area, largest muscle group, and easiest target, so to speak. And we also provide CPR shields for rescue breathing. Signs of an opioid overdose. This comes from the National Harm Reduction Coalition site. Loss of consciousness, unresponsive to outside stimulation. One of the tips that we give to our participants to check to see if someone is in overdose is a sternum rub. So take the knuckles and rub the sternum. If someone is not responsive to that, which is painful if done right, then, in all likelihood, they are overdosing. Awake but unable to talk. Breathing is very slow, shallow, erratic, or has stopped. For lighter skinned people, the skin tone turns bluish or purple. For darker skinned people, it turns grayish or ashen. Choking sounds or snore-like gurgling noise, sometimes called a death rattle. Vomiting. The body is very limp. Face is very pale or clammy. Fingernails and lips turn blue or purple black. That's, again, lack of oxygen to blood. And the pulse or heartbeat is slow, erratic, or not there at all. As I said, we give injectable Narcan and nasal Narcan. Here's an example of the two kits. The injectable Narcan we put in a container with emergency response prompts on the outside. The nasal Narcan comes in a box, and we wrap a brochure around it using a rubber band. Here's an example of the flyer for our nasal Narcan. You see on the left, MAT providers, substance use disorder treatment providers, and then instructions on how to administer it. Again, call 911. It's very important, something that I try to encourage our participants to do. There are other health issues that can be associated with overdose, heart attack, stroke, etc., as well as someone slipping back into an overdose. So, if someone is carrying enough of an opiate load in their system, and the Narcan, which is administered, metabolizes and starts to wear off, basically, someone can slip back into an overdose. So calling 911 and getting expert help is advisable, although there is fear also from our participants about calling 911. So I try to, encourage them to do so anyways, save a life. And stick with the person, stick with them. Again, having a partner is very important. This is our injectable Narcan. Again, this brochure goes within that black container, along with the 2 vials and 2 intermuscular syringes that are provided. And we put alcohol wipes in there as well, although in all honesty, persons are probably not cleaning the skin before they're injecting Narcan. The syringe that we provide is it's thick and long, so it can even go through jeans, clothing, a jacket, etc. And again, instructions on administering that Narcan, including here you'll see the muscle groups that are recommended: thigh, rear end, and the arms. I also give instruction on ways to draw that Narcan out of the vial. If one puts a little bit of air into the syringe before they put it in to the vial and then inject the air, it creates pressure and it makes it far easier to draw all of the Narcan out of the vial. And if someone is new to Narcan, by the way, and they're not sure what to do, I usually advise that the person use nasal Narcan. I actually talked with a participant the other day who said that he had nasal and intermuscular Narcan and used them both, but he said it was a real struggle to use the intermuscular Narcan because of the nerves in the moment. If you could imagine taking the syringe out and drawing out the vial, if it's not something that you're used to doing, and in the moment when someone is actually having an overdose and you're trying to save a life, it's just far easier to use the nasal Narcan, fewer steps. We have handed out nearly 900 doses of Narcan this calendar year for distribution outside of the exchange. So again, we have the prompts and we distribute it to our primary participants that come in, and then also give as many doses as they want. I'd say, hey, it's not doing us any good on the shelf. So as long as you're aware of how to use it, we put the brochures on it and try to get it out into the community as much as possible in education on it. But we also respond to requests. We have given it to juvenile hall, hotels and shelters, the sheriff's office, California State Parks, and county outreach workers, so that when they do perform outreach, that they are able to distribute Narcan as well. And we use the primarily the nasal Narcan for that purpose. Life saves. Our participants have reported 199 overdoses reversed using Narcan from January through the end of August of this year. It's a key part to our program, and something that I'm very happy that we're able to do. And as I said, I try to push it off of our shelves. It's a life-saving drug, and the side effects of Narcan are withdrawal, which is not comfortable, of course. And unless someone has an allergy to it, and I've yet to run into someone who does have an allergy, although I'm sure there are, the side effects are withdrawal. Something that I've been discussing with our participants is that in most of the Narcan training videos and also on the brochures, we do advise that you wait 2 to 3 minutes before administering the second dose. But again, if someone's nervous and gives multiple doses within that 2 minutes, the side effects are going to be withdrawal, so it's not the end of the world if someone does administer doses too quickly, especially with fentanyl use. It often takes more than one dose of Narcan anyways to reverse a fentanyl overdose. There is a new formulation of naloxone, which is in large part formulated. It's the double the strength because synthetic opiates often do take more than one dose of Narcan. So doubling the strength of the naloxone is aimed at reversing those overdoses more quickly. So again, if it's double the dose and they're getting it all at once, withdrawals are uncomfortable, but it's not the end of the world if there are multiple doses administered within that 2 to 3 minute waiting period. And with that, I will end that presentation. Forgive me as I pull up the screen here.
Awesome. Thank you very much, Mr. Williams. We really appreciate it. There's some insight in there. There's some things that I didn't know and some myths dispelled, which I think is really helpful. Again, I really appreciate everything you have to say. Commissioner Plum, you have your hand up?
Mute off. My mute's now off. Hi. So I have two comments. One, that was a really great presentation. Thank you very much, Rashawn. My first comment was about pre-filled syringes for Narcan. If people are nervous about filling a syringe out of a vial, I think pre-filled syringes are available. They may be more expensive, but if you want to reverse a narcotic overdose, you don't want to be filling a syringe. You want to pull that syringe out and get it into them. And then as far as the dosing and the withdrawal, it's pretty hard to get someone reversed from a narcotic overdose into a neutral state. So you're almost certain going to be putting them into withdrawal. And I think giving, withdrawal sort of has an endpoint. You reverse it all. Usually with the first dose of Narcan, all the opioid receptors are unroughed and they're going to be in full withdrawal. So giving large doses of reversal for someone who's blue and unresponsive is, the withdrawal is what you have to deal with, and you will need to manage the withdrawal symptoms, but hopefully you'll be in the hands of a healthcare provider by then. So those are my two comments. Thank you.
Thank you.
Any other questions or comments from commissioners?
I have one more comment.
Please.
I want to know where Rashawn gets his background from, because I want it. That's the best background I've ever seen in a Zoom meeting. So.
Oh well, this is a team's background, and poke around a little bit, and you'll find it. It hides my messes.
Yeah. Okay. It looks good. It looks like you're just getting ready to go back to the bar. Work on your ballet moves.
Okay, Commissioner King.
Just a quick comment that I really appreciate the education and the referrals that you're doing. I think that adds real depth to our program. I think it's a very valuable component. So I just want to give you my kudos for that. Thank you.
Awesome. So if there are no more questions or comments from the commissioners, we will say thank you very much, Mr. Williams. We really appreciate your presentation. At this point, let me see if I can read this properly here. At this point, we move on to item number 5 on the agenda, which is the time for public comment. Any person may address the commission for a period not to exceed 3 minutes on matters within the jurisdiction of the commission. And I have seen Mr. Cagnow's hand up for quite some time now. I don't know how to tell him to go ahead and talk. Nicole, could you tell me how to do that?
Let's see.
This is Serge. Can you hear me?
Oh, we can hear you. Yes.
Oh.
I can hear you.
Great. There you go.
Awesome.
Hey, Damon, it's been a while. And Rashawn, it's been hours since we were on a meeting together. Absolutely appreciate the work that you do and the presentation. And you mentioned International Overdose Awareness Day. I was wondering, has it been another meeting that you talked about the number of actual overdoses? Like, you talked a lot about lives saved, which is wonderful, but the ones that were not saved. And is there any way, I know that we have so many variables happening each year with your data about, there's another program, the other program has certain hours, you have certain hours, you sometimes have outreach. Any connection between, so talking about the overdoses that we've seen and the people we've lost, but also any relation to the number of hours that you're able to offer services and anything your program would like to do to try to lower the number of losses. Sorry, and I understand that I'm not always allowed to ask questions in public comment, but just wondering if that's allowed to slip through there just for a 20-second response.
Real quick, this is a formal commission, but we have chosen so far to run it where questions can be asked and short answers can be given. This isn't like going in front of the city council where you just speak and have no interaction. So yes, questions and comments are welcome as far as I'm concerned.
Cool. Thanks, Damon.
Well, it's really just about outreach. I know that we have Narcan that we dispense to the bench links camp, and there have been a lot of reversals there, but then also some death. And it's a hard question to answer. You wish sometimes that you could just be there with someone, and unfortunately you can't. So.
Okay. Hey, thanks for trying. I'm the new executive director of Recovery Cafe Santa Cruz, and I'm one of the collaborating partners with the SSP. So I hope you guys are all doing good, and thanks for the work that you guys all do.
Thank you, Serge. Good to hear from you. Is there anyone else that would like to speak during public comment? I don't know where I would look in the queue to see if there are other people that want to talk. Ms. Meza, if you could
You're
help me
good.
with that.
I don't see anyone else. I don't
Nobody
see anyone
here?
else, Recruiter.
Okay, well, with that, we'll move on to item number 6. Continuing action and business items.
I think I'm so sorry. Does Commissioner Plum have his hand raised?
I do not.
Oh, sorry. The hand was up. Oh, there it goes. Okay, I'm so sorry. Please continue, Recruiter.
Thank you, though.
Thank you, Ms. Meza. I appreciate all the help I can get. So item number 6 is continuing action and business items. Subsection A is follow up on information we learned from Tom Goncharoff, Department of Public Works, and that was concerning the oh great, now the name escapes me, Med Project, and the presentation he gave on that. Do we have any updates or any more information?
I wanted us to just not drop that off the list. And I get it that it's past 7:30. And so now we're an hour and a half into our meeting. I wanted us not to lose that. And also the subject of the discrepancies between the way that kiosks were handled. That's why I wanted to add those two things to the list. And because we're an hour and a half into this meeting, my wish or my proposal is that we just carry that on to the next meeting so that we can spend a little bit of time talking about the things that we heard in those two meetings. I don't know that tonight we have time for it, because to me it warrants some discussion. So my proposal is, can we just carry that over to the next meeting and spend a little time on it next time?
Do we have to make motion and vote to have that added to next month's agenda, or?
That's my understanding from our conversation last month, is that we have to make these proposals about what gets added to the agenda and we need a vote on it.
Okay, I believe that as chairperson, I'm not allowed to make motions.
Okay, well then I'm making those motions.
Okay, could you tighten your motion up just succinctly, just a little bit?
I'm afraid I
exactly
can't. I can't look, I'm pretty much IT inept, and so I don't know how to look at the agenda and repeat exactly what the language is. But on the agenda that I looked at just briefly, there are these two additions. There are two sentences, really, about things that I was asking that we add to the agenda. Can someone else help me with that?
I am seeing under new business, item number 7 was how to engage the public. And number 8, topics for future meetings or action items, was a follow-up on most recent legislation, AB 1344, and State Department of Public Health needle and syringe exchange services. Are those what you were referring to?
Certainly the first one, and also the second one. The other concept was we had two different discussions with two different people about what ends up in a kiosk. How much of the weight of the actual kiosk is actually syringes? Where do they come from? All of that. But we heard two different sets of information. And I wanted for us to take some time to talk about the differences between what we heard in those conversations. So my proposal is that we first talk about that subject, and the other one was, I forget already. What was the first one that you read there?
How to engage the public.
No, after that.
After
Number 8.
Follow up on the recent legislation, the AB 1344.
That's it. So my proposal is that we have those two things again on the agenda for next time, and that we spend some time talking about that.
Okay, so we have a motion on the floor from Commissioner King that we devote some time into researching the AB 1344 bill, and that we devote time to discussing the med project and kiosk retrieval systems and mechanisms and how we can refine them.
Yes.
So we have that motion on the floor. Do we have a
So
second?
we need a second.
I'll second that motion of Commissioner King.
Okay, we have a motion and a second. So all of those in favor of this motion, please say aye.
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 Aye. That passes unanimously with everyone in attendance. That sounds great. On that note, can I recommend that potentially we have a presentation or Mr. Goncharoff's replacement with the county? He was running the med project, but then he retired right after giving us his presentation. So whoever his replacement is, if we could have that person possibly be here to help with our discussion and answer questions for us and refresh us a little bit. I'm wondering if that's a good idea.
Is it a good idea? Yes. Yes. Is it possible? I guess that's a staff question, right?
I think that would be a staff question, and I think Ms. Meza and Ms. Holland are both looking at me like, what did you just do to me?
It's fine. Thank you, Chair Breeder. We will look into that for you.
Okay.
If it's possible, awesome. If not, well, then we'll figure out how to answer the questions ourselves.
Okay. Thank you.
Thank you. Okay, so that's continuing action, business items, follow-up information. Okay, so we sort of merged item 6 and item 8 together there, seemingly. So let's back up one click to item number 7. It's a new business or action item. How do we engage the public? I feel that due to the time of the evening and such things, that maybe that's something that we should just carry forward in, and that would go in item number 8 for next meeting. Topics for future meetings and action items. Is that how that works? Okay. Do I have to make a motion to do that?
That's a good question. I'm not sure that it has to. If it's just staying in the same space, then it doesn't. I don't think we need a motion.
Yeah, I think we're just carrying it over.
I'll just carry it forward.
Okay, that would be awesome. And when we have our monthly agenda setting meeting, then it gets set for sure and publicly noticed properly and all that kind of stuff, right? Okay. All right. Well, that leaves us with item number 9. Before we get to item number 9, I would like to ask if there's any questions or comments from the commissioners that, something that might need to be said right now. Anything? Anybody? No? Well, then we can move on to item 9, but I can't make the motion.
I move we adjourn.
And I second the
Second
motion.
that motion.
Okay, we have a motion to adjourn and it's seconded. All those in favor say aye.
Aye.
Aye. I think everybody ayed. So that concludes the September 14th, 2021 meeting of the Syringe Services Program Commission. Thank you very much, everyone. I really appreciate you all being here and putting up with me through this first go round.
Nice
Thank
Good
you,
job.
job, Commissioner Brewer.
Thank you.
Nice
Good
job.
job, Damon.
Thank you. We'll
Bye.
see you next month.
Good night.
Thanks, Damon. Good job, Damon.
Thank you. I appreciate it all.